Here we go. Hi, everyone. Welcome back to Misconceptions. I'm really excited for this conversation today. I am joined today by Dr. Devorah Segal, and you are going to meet not only as a woman on the top of her field, but also somebody who I've met a few times professionally and just so impressed by her. And welcome, Dr. Segal. We'll see where this conversation goes. So glad you're here.
Thank you so much. I'm really glad to be here. Thanks for having
So,
me.
absolutely. So, we primarily talk about maternal and reproductive mental health, but I also just like to bring interesting medical topics and cultural topics to the community. But before we get into the identified topic that we're planning on doing together, I want to hear a little bit more about you and your training because you have been in school a really long time before you
I
became a
have been.
physician. Tell me a bit about yourself.
Sure. I grew up in Brooklyn. I went to, grew up in Flatbush, regular Flatbush Brooklyn family. I was always interested in the brain from a really young age and had I had a plan to do a PhD, do research on the brain. My specific interest was in language acquisition, actually. So I was planning on studying how the brain learns language and how that's different in children with learning disabilities, for example, and neurotypical kids. Um, and as I went through college, I'll give you the somewhat abridged version. Basically, people in my life who were in the field and were experienced in medicine and research convinced me that if I wanted to do research involving people, I should get an MD. I should go to medical school and do a PhD or a research degree at the same time. So that way I have more flexibility and can sort of run my own studies, run my own research without needing to partner with other people. So I did what's called a combined MD PhD program. So for me, it took 8 years. It's 2 years of medical school, then spending 4 years in a lab to do a PhD, where I studied white matter changes in the brain and schizophrenia. So very different from
Ooh,
what I thought I was interested in, but a really fascinating project. And then I went back and finished the last 2 years of medical school. And along that pathway, those 8 years in school, I discovered that as much as I like research, I actually really loved taking care of patients, which was a shock to me. I did not expect that at all. I always thought I was just completely research focused, but the taking care of patients, working with people really spoke to me in a way that research didn't always speak to me. So I also discovered that I loved working with children, which was another surprise. I had gotten married in my second year of medical school. I had 5 children along the way. Can I now including twins? So it was a
you
very
make
busy
that sound
8 years.
easy. You're like, oh, I just like had five kids. And like, oh, I just, hey, can we just take a moment and be like,
Yeah,
okay, so you had five children
I
through
did.
a tremendous amount of training and a tremendous amount of
Yes.
responsibility. Okay.
Yes.
Yeah.
And at one point, I have twins. My numbers 3 and 4 were twins. So at one point, I had 4 children under 3. My oldest was
Mm,
2.5. My second was 17 months. And then when my twins were born, I was in the middle of my PhD, which actually gave me a little more flexibility than being in the medical school years.
right.
But it is kind of a blur. I
Yeah.
don't really, those first 6 months after my twins were born, I don't remember much, to be honest. But I did have a lot of support from my husband. Our families really stepped up when we needed it, which was wonderful. And I did get through the training, through the 8 years of schooling. I decided to do a residency in pediatric neurology, which is focused on brain diseases in children. So that includes things like seizures, things like stroke in children, which has happened, developmental delays, lots of different migraines, tics, some of the less scary things that are brain disorders in children. And then by the end of it, I wanted to sort of focus on something that would bring me back to my research base and allow me to do things like clinical trials and clinical research. So, meaning not working in a lab with microscopes and mice and doing those kinds of experiments, but more research that was directly involved in patient care and directly affected patient care. So, I ended up doing a fellowship, which is a 1 year additional training after residency, which was 5 years for pediatric neurology. I did a 1 year fellowship in pediatric neuro-oncology, which focuses on brain tumors in children and genetic conditions that predispose people to developing tumors. So altogether, that was 14 years of training after college, 8 years of MD PhD, 5 years of residency, 1 year of fellowship, which sounds like a long time, and it is, but it got me to a job that I love. I just love what I do every day. I feel really privileged to have the position that I have, to be able to work with the children and the families that I work with, and also do research that directly affects their care. Clinical trials, which means trying new medications for diseases that we might not have treatment for, and clinical research where we try to learn more from our patients to try to, let's say, figure out what the best treatment is or how to minimize side effects of treatment, et cetera, to make their care better.
So most of the patients you're seeing today are going to have some form of brain tumors at this point, and
So
or
I
potentially have
see
been treated like by others and now are coming to you for like a last chance.
Yeah, so I
Okay.
see a few different kinds of patients. I see children with new brain tumors or second opinions for brain tumors. I tend to focus on the non-aggressive malignant kind. My work partner focuses more on the very malignant aggressive tumors. I usually treat patients with what's called low-grade tumors. So these are tumors that they can live decades with or even their whole life with, but do need treatment along the way, whether it's surgery, chemotherapy, radiation, or some combination of those. I also treat adult survivors of pediatric brain tumors because oftentimes just having had a brain tumor in that very delicate area of development can cause long-term consequences. And then
Mm,
sometimes the treatments, the surgery, the radiation, the chemotherapy can cause long-term symptoms that really needs someone who has experience in treating those specific things. So I treat
mhm,
adult survivors of pediatric brain tumors, and then I see children and adults with certain genetic conditions that can predispose them to tumors. So that's more often sort of long-term surveillance, checking in annually, making sure there are no new issues, ordering tests if we need to, but not necessarily active treatment at any
mhm,
given time.
mhm. Okay, so before we get into the kind of the subject matter at hand, do you mind if I ask you a few questions of what it means to be a mother
Not at all.
first? About, okay, so talk to me a little bit about, when I hear 14 years of training and I know that you have, Baruch Hashem, a beautiful family and a lot of support, I'm wondering how you kind of navigated this conflict of motherhood, the mothering identity being a tremendous professional, and also kind of that pull and tug between home and work. I feel like a lot of women really are struggling with like where I belong or where I belong in two places. What were some of the things that contributed to your figuring out who you are in navigating mothering and the work environment that you were committed to?
It's a really important question and one that doesn't have any simple answers. I do think that for me, being a doctor and in the field that I am in, I think that made me a better mother because it gave me perspective. And I'm not saying that you have to be a doctor and take care of kids with cancer to be a good mother, not at all. But for me, I think it really gave me perspective on what the big things are and what the small things are, and
Hmm.
don't sweat the
Hmm.
small stuff. It also gave me a level of fulfillment that I think for me, staying at home full time, and I think that's a really beautiful thing, but it would be very difficult for me to do, to be a full-time stay-at-home mother. And I needed this outside outlet sort of for my energies, in order to feel more fulfillment in my time at home, if that
Hmm.
makes sense.
Yeah.
So, and I also think that for me, being a mother really added to what I do as a physician. And again, you can be an amazing doctor without being a parent, and one is not a requirement for the other. But it's interesting because when I was training, I remember I worked with a pediatric cardiologist. He was one of my mentors, and he told me, he said he feels like when he became a father, he earned this level of trust from his patients and their parents that he didn't have before, where they're like, oh, you're a dad, you get it, you understand where I'm coming from. And for sure, being a mother, I think adds a lot to my credibility, to my just ability to empathize with parents who are going through a really hard thing. And Blia and Hara, Baruch Hashem, I never had to go through anything like this with kids, but we all have challenges as a parent. Life is not a straight path, and things don't always turn out the way we hope. Things are not always easy. And I think I was able to bring that perspective just to understanding my patients, my parents. And very often when you're in a pediatric field, the child is my patient, but the parent is also my
Oh,
patient.
for sure.
Because,
Yeah.
just supporting families through this, the child needs their parent support to be able to get through something hard. And in order to have the parent support, the parent needs my support. So
Mhm.
I think being able to bring that perspective as a mother helps me a lot.
Mhm.
Sometimes even just being able to say, oh, this is nothing. You don't have to worry about that. Three of my kids did the same thing. They're fine. So I do think it lent me a degree of credibility and helped
Sure.
me. sort of be a better physician.
Right.
But that's not to downplay the challenges of trying to be both. And as a mother, which I think fathers don't deal with the same thing, to me, I'm never one or the other. I'm always a
Mm,
mother at the same time, no matter what's going on in my work life. I can be in a major work crisis with someone who's really sick, who needs my full attention, and there's still a part of my brain that's focused on my kids and where
mhm,
they are at any moment. And if my phone rings and it's the school nurse or it's one of my kids, you know, I that part of my brain is always still engaged, which I
mhm,
think um it you know I'm trying to figure out the right way to say this. I think it's a challenge. It's also something that women tend to be better at, keeping that
multiple
multitasking,
tabs
keeping,
on the
yeah,
computer
exactly,
open.
multiple
Right,
tabs. That's a
right,
great analogy, keeping them all
right.
open at the same time. Um, People talk about juggling, and I think juggling is a good metaphor because in juggling, you're keeping your eye on all the balls at the same time, but you're only actively holding one at any
Mm,
given moment.
hmm.
I can't hold them all at any given point in time, but they're all sort of open in the background. Um, my kids know that if they call me during work, I will pick up pretty much no matter what. But if I'm in the middle of something, I'll say, "Hi, is this an emergency?" And if they say no, I say, "Okay, can you call back in an hour? I'm in the middle of something else." So I think they know that they can always reach me, but they also know that sometimes something else needs my immediate attention more than they do.
Hmm.
And with my patients, I really try to set boundaries to as much as I can. I am available 24/7, not to them necessarily, but to the other doctors in my practice. So if I'm
Mm,
not on call and a patient calls and the layers, the fellow and the other attending and the other doctors covering can't handle something because they're not sure what to do or requires a degree of experience or expertise that they don't have, they know they can reach me. But
huh?
at the same time, I'm not answering my work email when I'm out with my family. It's turned off on my phone. I don't get those notifications, etc. So
Hmm.
I think I like that tab analogy. Those tabs are always open. They're always sort of living at the back of my head, but what's front and center sort of varies with time. That's the ball that I'm holding at any given moment.
So can I ask you one other
That,
question? Like
yeah.
when I think about women trying to confront like that, actually, I am a better mother if I am working or if I have this other part of my brain highly, activated and highly functioning. How long did it take you to reach that? Like sometimes I wonder that I feel like some people are still in that conflict of like claiming I'm a working mom and I'm okay being a working parent and I'm juggling, but also like kind of like the juggle, like that perspective did it take you time? Because I don't necessarily think like that messaging is always really culturally aligned.
Yeah, you're absolutely right. And I think that I grew up with a working mother, so she worked full time most of my childhood. So I had a model to look towards for how you can do both. And I knew that my mother was and is an incredible mother, even though she worked a very high powered, high stress job. So to me, I think I was raised with the feeling that you didn't have to choose one or the other, which is not so common in our community,
Right.
and helped me a lot. So I think maybe I struggled a little bit less with it than other people because I did have that role model. But even
Hmm.
so, there's a lot of justifying that we
Yeah.
go through.
Yeah.
Like, yes, I'm out of the house for these hours, but my time with my kids is so high quality and it's so high
Yes.
intensity.
Right. Right.
And it did take me time to realize I don't have to justify anything.
Right. Right.
I am what I am. They are who they are. And I do think that I'm better for having both of these parts in my life, which
Hmm.
is something very specific to me that
Right.
doesn't work for other people necessarily, and that's okay. But it
Right.
did take me time to get there.
Yeah, I feel like it's a conflict that so many women struggle with, but don't necessarily have support in claiming the other part. We have a lot of support in claiming the motherhood and the maybe like the semi stay at home or mostly stay at home mothering, but we're not heavily focused on supporting the ones that are, and most of us are working nowadays. Like it's actually quite
Yeah.
unusual that women are staying at home. And I think that we're kind of like trying to play catch up and like, oh, like our structure of our families actually have changed. And we're not stay-at-home moms running carpools any. I mean, we're also running the carpools and also, working full time,
Not me. I paid for
right?
bus service.
Good for
I just
you.
didn't.
I
Carpool is
paid for
not.
homework helping. That was my
Yeah.
thing. I was like, I
Yeah.
could do the carpools, but I am not doing the homework.
Yeah,
So
I do think that it took time for me to recognize that we all have things that we're good at, and it's okay to offload, and things that we want to do, and things that we
Mhm.
don't want to do, and it's okay to offload and pay someone else to do those things that
Yeah.
just don't work with our personalities or our time, and preserve the stronger parts of our relationships with our kids.
Yeah. I
Um,
wish more women were open about the amount of help they actually have. Because I think sometimes they like display it as like, and I do all these wonderful, amazing things. And you're like, yeah, but I also know you and you have full-time nanny, or you have two
yeah.
women living in your basement. Like, could we be honest about like what kind of help was needed to do all the things? So,
Right. Yeah,
but
even someone asked me last night, someone I had recently met and asked what I do. And I told her, she said, "Oh, when do you have time to do laundry?" And I said, "I haven't done laundry since 2020. I don't do
good for you.
laundry. I have
Right?
someone who does my laundry for me, and I'm not
Exactly.
ashamed of that."
Good for you.
There are other things
Exactly.
I do that I don't outsource, and there are things that I outsource because that just is what
Because
works
you
for me and my
can.
schedule. And I
And also
can.
because you
Yeah.
can, right?
Yeah.
Okay.
Yeah.
Thank you for
Yeah.
letting me go down that little bit of a rabbit hole because I think it's an important thing when I put somebody of your level of training and education and not like, I want to always clarify what that actually looks like. Because I find there's so much stigma around like, I'm not good enough and I'm not confident or accomplished enough. And like, I think we have to be honest about what that looks like. And so I appreciate the honesty of and the conflict in it as well.
I
Okay.
want to
So
just add one more piece. I'm
please,
sorry. I hope you don't mind. I'm
not at
derailing. You
all. I
derailed, and
want
I'm
you to.
derailing.
I want you to.
I do think that for me, especially knowing that the job that I do has inherent value for my community, and not knocking any other job. Every job is a good job. There's no such thing as a bad job. But I see that the job that I do is chesed in and of itself and has value in and of itself. So that
Mhm,
for me helps a lot. That I
mhm,
know
mhm.
even if I'm taking time away from my family to dedicate to a patient, it's a
Right.
patient who I'm making a difference in their life and they need me right now. And it's something that in and of itself is a mitzvah and a chesed. So
Right.
for me, I think that helps with the splitting as well and helps me feel that what I'm doing has inherent value separate from the self-actualization that it
Yeah.
gives.
Yeah. Thank you. Thank you for that. And just for anybody who's not familiar with the language, it's a mitzvah is like a commandment, but also a chesed is an act of kindness, a kind deed that is also in many ways spiritually commanded to us. And so kind of having this like value to the work we do holds a tremendous impact. Okay, so let's talk a little bit. Let's talk medicine. Let's talk medical. The thing we wanted to talk about was introducing this idea of some of it is cultural and some of it is communal and some of it is just I don't know how to do this differently. But I want you to take me through a little bit about what we know from when there is a childhood cancer diagnosis and what are some of the like kind of I wanted you to talk to me about your best recommendations in terms of talking to children about their own diagnosis. And then we're going to get into the where things go off the rails in terms of disclosure and what children know and are not told, and where we're finding conflict in that. So let's start with the diagnosis.
So I have very strong feelings about this, and they are evidence-based and not just my own personal feelings. So one thing is that to keep in mind is that when someone gets a cancer diagnosis, it doesn't come out of nowhere, right? The
Right.
testing wasn't done for fun. It was done because there's a problem, there's a symptom, whether it's fatigue or ongoing fevers or unusual bruising or a mass or a seizure or something. There's something that led to the diagnosis. So the child is having a symptom, is having an experience that is abnormal, and that results in, worst case scenario, in a cancer diagnosis. We believe that children in an age appropriate way should be aware of what's going on with their health really from the beginning. And when I say an age appropriate way, the language might change based on the child's developmental stage and cognitive stage. The how much they know might change, so they don't necessarily need all the information all at once, right? We can start with something like there's a problem in your liver, or there's something in your brain that shouldn't be there. Again, with the language depending on the cognitive stage, and then adding information with time. They don't need to know everything all at once, but they should be kept in the loop and they should be made aware of diagnoses pretty early on. And the reason for that is really, like I said before, a diagnosis doesn't come in a vacuum, and a child knows that something was wrong. That's why they go to the doctor, right? They're not just going
Right.
just because that's today's vacation activity. Um, and keeping information from them just allows them to think of the scariest possible outcome. And then the other piece is that kids are very good at picking up on the emotional tenor of their family.
Sure.
We know whenever parents are under stress, whether it's from interpersonal relationships or financial stress or an illness in someone else in the family, everyone in that child's life knows something is not quite right. Their teachers know, their friends know, because the child picks up on it, and that can come out in many different ways. So when a child has a sense that something's not right, they have a sense that, wait, I'm going to more doctor's appointments, I'm getting these blood tests, my parents are whispering behind my back, but doesn't know what that is, they tend to go to the worst possible conclusion. Either I'm dying, my parent is dying, something else is terrible that's going to happen, and no one wants me to know. Um, so for both of those reasons, we believe that it's really important to disclose a diagnosis and to have children part of the conversation early on. The other piece is that there are things that children, even though the legal age of consent is 18, there is a concept of assent, where a child over about 7 does have the right to have a say in their own care. And that
Hmm.
a parent, even though the ultimate decision-making capacity is the parents, and children are, they're not developmentally able to make certain big decisions for themselves, it's not ethical to, let's say, not tell a 10-year-old that they're having surgery and they wake up afterwards and say, what is this on my head? A child needs to have some sense of ownership over their own body and over what happens to them. And that's both from an ethical perspective and from a safety perspective. We don't want to raise our children to have the feeling that adults can do what they want and I don't have a say, right? That's
Oh,
very
yeah.
unsafe.
Hmm. When, where do you find in this process? Um, it's so interesting. We talk about this concept of consenting for us versus assenting. And the thing that's striking me is how often I've interacted with parents who are like, my child doesn't need to know. They just need to know that mommy and daddy are here, mommy and tati, right, are here, and we are taking care of things, and they have something wrong, but we're going to make it better. And that's the entire like conversation. And that culturally, there is a tremendous amount of kind of deference to the adult in the room under so many different circumstances, right? And I think about that from, first of all, the child finding out later, but more importantly, like how does the medical world navigate that where the medical team is going, we don't agree with this. Like we don't agree with this lack of disclosure. But then there's this cultural humility of, well, this is the culture of the community in which we're serving. How do you navigate that?
That's a really, really interesting and difficult situation to be in sometimes. So a lot of it is for sure cultural, and even within, the Orthodox Jewish community of which I'm a part, there are different streams, and there are some components of or parts of the community who are very much like, we're not going to tell the child anything until they're 18, even if it directly affects themselves and their future. And other components are or parts of the community that are a little bit more open, but it's not isolated to any one culture or community. I see it in families from every socioeconomic, cultural, ethnic background where some families just have this strong feeling like the parent makes the decision, the child will just rely on us and have complete and utter faith. And we don't believe that's the right way to go about it. And we have, from experience, we know that that's not the right way to go about it for the vast majority of children, of cognitively intact children. When this does happen, we will never directly go against a parent's will, because that's not my right. I'm not the parent's child or the child's parent. And we do have to understand that sometimes a parent does know their child better than I do in many ways. And even if they don't, I don't have the right, as long as it's not
Right.
something that's dangerous or
Sure.
medically wrong, I don't have the right to impose my values on this family. But we will do is we'll have a lot of ongoing conversations with the parents. And sometimes it's a process. Sometimes we need to introduce the concept slowly, and then the next time they come in, have the conversation again. I bring in my child life and we have mental health professionals in our clinic. I have a psychologist, a social worker, a psychiatrist, so bring them in to help as well. I'm also very fortunate to have both child life professionals and a psychologist who can do coaching with parents. So sometimes parents say, well, I think you're right. I think it's time to talk to my child about what they have, but I just don't know how to say it.
Right.
And they'll practice with them, role play, give them scripts or words that they can use. And I think when we explain to parents why we feel this way, how they can go about it in a way that is comfortable for them and comfortable for their child, I would say 98% of the time we get there. We come
Hmm.
to consensus. We get to the point where both we as a medical team and the parents are comfortable with our plan and how we intend to communicate with the child. I've
Yeah.
had a few, really like probably fewer than five, maybe two or three families over the course of the years that I've been practicing where the parents, no matter what we said or how we explained it, the parents flat out said, absolutely not. I know what's best, and I'm not telling my child that. And I would never, I would try at every visit, bring it up again. But I don't think it's my role to say, well, too bad, I'm telling your kid something that you don't want them to know.
So they were not being told, they were being not told that they had cancer or not being told the implication of the cancer. Like, I'm just curious where the line was for them.
Sometimes they don't even know that anything is wrong with them. I mean, I had a patient who I was seeing for a few years who had a genetic condition and a
Okay.
tumor, and were not told that. They were told that I was just a doctor who does checkups, and they get pictures of their brain because sometimes people get pictures of their brain. They were
Wow.
not told that this was something that was specific to them. And as the child got older, we made clear to the parents that this child is going to figure something out on their own, and that can be just so damaging to that trusting relationship that you want between a parent and child. And actually, this family, I don't know if I did the wrong thing, but I brought it up at every visit, with the parents separately, and eventually they found they got care somewhere else. I haven't seen them in a few years.
Really, really.
Yeah.
Yeah, but that kid's gonna turn to the friend and be like, so when you get your brain picture
Yeah.
taken, right?
Yeah.
And the kids are gonna look at you like, what is
What are
wrong
you
with what are
talking
you
about?
talking about?
Exactly. I mean,
Yeah,
I hope that they're getting good care and they're doing what they need to do. And, there are other doctors out there. I'm not the only one.
yeah,
But
yeah,
I feel a little bit bad that they felt they had to go somewhere else. But at the same time, I do feel like I said what I needed to say. And it, I don't know where they are right now, but it would have been
sure.
for the better interest of both
Yeah,
the parent and the child if we had had an open conversation, not sort of shut down with it.
right.
But almost in every other case, we're able to come to a point where the parents say, you're right, I think we're ready now. Sometimes it just takes a few years, and that's okay.
Yeah. And I can understand why a parent might feel like they can hold some of that information for different circumstances. I think where I see it showing up quite a bit is where we're talking about reproduction and the future reproductive capacity of a child. And so where I'm finding is that often that component of their care is kind of like, we're not going there. We're not going to discuss that. We're not going to discuss at all. Even if they do like reproduct, I've even had people who have done fertility preservation without really explaining to the children why they're doing it, or have actually had done like retrieval of sperm under sedation,
Yep.
and did not disclose to the male child why that was being done. And I understand, culturally there's something quite dignified about the parents holding the we are in charge of keeping you safe, healthy, and whatever, and we're telling you that this needs to be done. So there's something like, wow, the respect to the parents, but the consequences of it worry me so much.
Yes, and I've seen that as well. I think especially in sort of more traditional and sort of sheltered communities, that is often reproductive health, reproductive futures is something that's really not talked about with children until they become adults.
Yeah.
So anything having to do with reproductive health or their reproductive future is kept as the parents keeping this. I like how you said it, keeping this information safe, and they'll share it with the child when they're ready. And that's where there's a cultural, I think you can't ignore the cultural context that is really important. I've had young women, who are 17, and I say to the parent, I think she has to know that she has a genetic disorder that she can pass on to her child. And they say things like, well, she really doesn't know anything about that stuff, so we're going to wait until she's 18. So I've never had anyone where they don't tell them at all, but sometimes families wait longer than I feel comfortable with. But that's another area where I say, okay, I
Right.
understand this is your cultural context. We just need to come up with a plan and make sure we do have a time when we're going to have this
Yeah.
conversation with this child who's now an adult.
Yeah.
Um, I have had kids also who were not told that, that their treatment puts them at risk of infertility in the future. I had one kid who was when they found out, and I'm keeping everything vague on purpose, not
Sure.
clarifying genders or anything, they were about probably 14 when they found out that there was a good possibility they wouldn't be able to have children in the future. And there was a complete breakdown in my office. It was
Ah,
devastating to this child. And now I'm not saying that that child should have been made aware of that conversation at 7 or 8. But I think maybe if they had been a little bit more aware along the way, it would have been easier to
yeah.
understand and to incorporate into their sense of self.
It's one of those things actually that I've worked pretty closely with quite a number of families on in terms of like how do we tell our child that they don't have a uterus? How do we tell our child that they have a CIS diagnosis? Like how do I tell my child that there is a genetic concern or that they cannot have a child, a biological child, and or a genetic child? And it's parents always intend to tell, at least the ones I've worked with, like we intended, but time passed and all of a sudden they're 12 and 13 and 14 and 15 and 16. And like there's a point where I think the children learn not to ask anymore. So like for example, when we're working with a girl who doesn't have a period because she's not going to get a period. Um, initially they're like, where am I getting my period? And when, if they're even asking, and then there becomes a point where I think the child knows this isn't something I should be asking
We don't
about
discuss
anymore.
it.
Like we
Yeah.
can't discuss that,
Yeah.
which also creates so much secrecy around their body, around physical development of the things we could talk about, things I'm getting these messages that I cannot talk about from a psychological perspective is really risky,
Yeah.
really, really risky.
Right.
Yeah.
And back to that safety issue,
Yes.
it really is unsafe. I do think that, again, a 7 and 8-year-old probably should not have that
Right.
conversation. They're just not emotionally ready for it. But by the time they're hitting puberty, whether it's a girl who's not going to get her period, that's the perfect opportunity to have that conversation.
Hmm.
To
Hmm.
and it can happen organically.
Yeah.
I know your friends are talking about this. Your sisters had this experience, and we had a different conversation with your sister than we're going to have with you. And let's talk about what this means. And sometimes it can be introduced in chunks and little bits
Hmm.
as the child gets older. But often those developmental switches, those phases, is where a new concept can be introduced.
But I think also at the same time, one of the things that I hear is pushback is like, yeah, but her friends, what she's going to tell her friends, and then she's going to tell her bubby, and then she's going to tell her grandmother, and then she's going to like, and like the secret will be out. Or she will have nobody to talk to, right? Who is she going to tell this information to? And the conflict of do we tell her she needs to keep it a secret, right? The difference between a secret and something that's private versus secret. Like there's
Yeah.
so many pieces of this that I think these parents are really kind of trying to come to terms with that they end up just being like, I can't deal with this. Right. I don't know how to do this.
Right.
Right. So on one hand, both you and I might have that perspective of like, this would be the best. And then parents don't have that child life specialist in their back pocket to be like, tell me how to do this better. Right. How do I have this conversation?
Yeah.
When we think about, I think it's important to bring up because especially with from a reproductive perspective, but even more so like the risk of I have this diagnosis and now I know it and it's permanent, right? Like this is part of my medical history. And now I'm thinking about what is this going to mean for the future? And I have had parents say to me, like, I want to protect her so she doesn't have to worry about these things until she has to worry. Meaning, I won't tell her till she's 20. And then we're going to find out that we're not going to have shidduchim for her, that dating is going to be incredibly complicated, but at least she'll have had it 19 years where she was blissful. What are your thoughts on that?
Yeah, I've heard that, and I don't entirely disagree. And I think
Right.
that's where you have to really know your child and your cultural context. I've had kids where I had that exact conversation, where the parents said they had a genetic disorder that was dominant, so they have a 50% chance. Every child they have has a 50% chance of inheriting that disorder. And often different people in the family are affected in very different ways. So one person might be quite mild, but their child might be quite severely affected with many developmental and medical problems from it. So it's really important. And I've had families who say, well, we're going to talk to our child about that when they're 18 or when they start entering the marriage process, when we're starting to talk about matchmaking and shidduchim, because why should we have to worry about that before then? And I don't think it's, I hear that. I do hear that. For most children, it's much easier to learn something in bits and pieces as they grow up when this has always been part of their identity. I have this genetic disorder and I'm still a great person. And it's just like I have dark hair. I have this genetic disorder. It's just part of who I am. And then as they get older and are ready to think about the reproductive implications or the implications for future relationships, you can slowly introduce those concepts. And sometimes if they feel empowered and that it's not a secret, they'll start asking those questions themselves.
Right.
I saw a 14-year-old who started asking me those questions earlier this week. And it's something that I had discussed with their parents 5 years ago when this child was too young to even start thinking about it. But now that they're 14, they started asking me the questions on their own. Hey, well, what happens when I want to have kids? Is this something that my kids might have? And because they felt like their diagnosis was something that was always talked about, they felt empowered to ask their questions.
Hmm.
Whereas if now all of a sudden at 18, you're first starting to introduce this concept that there's something about you that's different than everyone else, having to reshape your whole concept of yourself at 18, I think for most kids is very difficult. Now, are there individuals out there for whom that is the most appropriate approach? Possibly.
Maybe.
Maybe.
But I think we also have to confront that the parent has to be in a space where they have confronted their differences.
Yeah.
Meaning, I've seen that parents really struggle with what their genetics hold and what they've passed down to their children or what their children have in their genes. Like they're confronting it from a if they're willing to confront it, often it begins from a place of tremendous shame and tremendous like discomfort. I understand, but tremendous shame. Like there's something broken in me and I have now passed that on to my child. Instead of like you say it so practically, and I'm like, wow, most people don't experience it in a practical way, right? There's serious like emotional intensity that goes along, and I want to acknowledge that. But like, the idea of bite-sized pieces makes the most sense. And also, some parents just haven't confronted it in any way, shape, or form on their own.
Yeah,
Yeah.
that's absolutely true. And I think I'm very fortunate that I can have longitudinal relationships with children and with families. So it's never a one-time conversation. It's something that we can talk about every year, every 6 months when you come to your follow-up, and we can readdress this and we can discuss, is now the time? What should I be telling them now? How do I talk to their siblings now that they have a sister who's 12 instead of 5 when we first got the diagnosis or whatever. And I think it's important to know that it's an evolving conversation and
Mhm.
very much specific to where the kid is at, where the parents are at, what their community setting is like, their cultural setting. So there's no one size fits all, even though the overarching theme of being open and discussing medical issues, I think stays the same for
Yeah.
most people.
And I think that that's one of those spaces that sometimes I feel like we're still trying to figure that out culturally. Like where do we sit with medical knowledge and information? Like I grew up in a time where cancer was referred to as Yanamachla, right? It was that disease in Yiddish, right? I didn't even speak Yiddish, but that's what we said. You know what I mean? Like we didn't say the word cancer. The idea of saying it out loud was like giving it power. And there was a lot of conflict. There was so much secrecy, and then they would just die, right? Like literally, like they
Right.
would just die, and there was never a discussion uh, in my childhood years of what happened, or it was in whispers. I think we've changed because I think that organizations
It still exists,
it's
believe
still
it or
no,
not,
I think the
but
existence
less
of
so.
yeah, less so. I think the organizations that support families with cancer have changed the narrative.
Yeah.
I do. And so all these different organizations that pop up to support and have camps for kids that have cancer diagnoses absolutely is going to impact the narrative as a culture and a community. But when it's your story, not necessarily. Not necessarily.
Yeah.
Yeah.
Yeah, there is still a lot of secrecy, and now whether that's because we don't want to be an object of pity or we don't want it to ruin shidduch and matchmaking for this child and all their siblings. We just don't want to talk about it. Ayin hara, the evil eye. There are lots of different reasons, but I think for the most part, the pluses outweigh the negatives,
I
both for the
agree.
child, where they feel like,
Yeah.
I mean, imagine a kid who's diagnosed with leukemia, is getting chemotherapy, feels sick all the time, is missing school, and feels like they're not allowed to tell any of their friends. So their
Right.
friends know they're not in school, but they're not allowed to talk about why. Holding that inside is an added burden on top of everything else that they're going through. And
Right.
then the parents too, the kind of support you get from family and friends, I think that outweighs the value of secrecy. And it's not like no one knows anything's going on. Everyone knows
Exactly.
something's going on. They just don't know what, which again
Exactly.
makes it even worse.
Right.
Siblings who don't know what their sibling is going through and just everyone's whispering about it. And she's always missing school and going to appointments, but nobody's telling me where or why. That's much scarier.
And it makes it like shameful. It does. I think that that secrecy introduces a shame of we have something to be embarrassed about. We have something
Right.
to be
What did
ashamed
we do
of.
wrong?
What do we
Why
do
is this
wrong?
happening to our
Exactly.
family?
Exactly.
Yeah,
Exactly. I'm wondering about can you talk a little bit more about genetically inherited predispositions to cancer? I don't think most people know about that. I'd like to talk a
sure.
little bit about that because that I think also like I want to follow up that question with how do we have these conversations with children who we have a known, like, there's some really significant concerns for the future. Talk to me a little bit about what it is, and then let's talk about how you talk about
Sure.
it.
So I just want to clarify sort of what I treat and what I don't treat so people understand the context of this conversation. I think when people think about, especially in the Ashkenazi Jewish world, think about genetic conditions that put one at risk for cancer, what most people think of as BRCA, right, which
Right.
is the breast cancer predisposition gene, raises risk of breast and ovarian cancer, and that's much more common in Ashkenazi Jewish families. That is a cancer of adulthood. So actually, from the genetic and cancer world, we feel that it is unethical to test children for a disease that will not
Mhm.
affect them until adulthood because a child needs to make that decision on their own, right? If
Okay.
this is not going to be an issue till your 20s or your 30s, I, as a parent, can't decide for my 8-year-old that I want to test for that. That's not fair.
Okay.
The conditions I treat or I monitor, mostly it's a condition called NF1, neurofibromatosis type 1, which is actually the second most common genetic disorder after sickle cell disease. It affects 1
Really?
in 2,500 people. So very, very common. In my clinic, we see well over 2,000 people with this disorder, all ages, and it predisposes, so women are at higher risk of breast cancer if they have that, but it also predisposes people towards brain tumors and tumors that are usually benign, can be malignant, that can grow along nerves in the body. And that risk starts in childhood, so some
Hmm.
of the brain tumor risk. So as opposed to something like BRCA, this is a disease that directly affects the child and affects the kind of surveillance and care that that child gets. It is autosomal dominant, which means there's no such thing as being a carrier for it. Either you have it or you don't. And for someone who does have it, they have a 50-50 chance of passing it on to each child that they have.
Okay.
Now, that said, about half of cases out there have inherited it from a parent, and half of cases out there, the child just developed it on their own. They were born
Oh,
with a
interesting.
mutation.
Okay.
Yeah, so that shame element that you talked about is not always there because at least 50% of the time, the parent didn't have it, that child
Wow.
did. And a lot
Okay.
of what I do when we make a diagnosis is emphasize for those parents, you didn't do anything. You didn't cause this. This is not your
Hmm.
fault. It's not because you took Tylenol when you were pregnant or
Right.
you went
Right.
into a sauna or whatever. Um, where was I going with this? So, but yes, these are children who the diagnosis is often made in infants or young children, and they do need added surveillance. They need eye doctor exams every 6 months until they're 6 to look for tumors behind the eye. They see me once a year, usually for monitoring. We talk to parents about certain symptoms that they should let us know about if they have it, because that might require an MRI or a blood test or something more intensive.
Typical diagnosis is found how in such early child? Is there
Yeah.
something visible? Something?
Yeah. So
Hmm.
there are certain birthmarks on the skin. They're called cafe au lait spots. They're dark spots
Hmm.
on the skin that most children, 98% of kids with NF1 will have them within the first few months of life, certainly
Hmm.
by age 2. So that's usually why they get referred to us, and then we confirm it either on an exam or with a blood test.
Interesting. Okay. So and by the way, Lynch syndrome, where does that fit in?
Yeah, so Lynch syndrome is another one. I do follow kids with
Okay.
Lynch syndrome as well. So Lynch syndrome is a different mutation, and those children and adults are at risk of certain aggressive malignant cancers,
Okay.
including certain kinds of brain tumors. Yeah, so
Okay.
people who know they have Lynch syndrome do need much more close monitoring, regular exams, MRIs, depending on their age.
And Lynch is
Um,
always inherited?
That's a really good question. Not necessarily, no. Sometimes it can also be sporadic. I don't have the exact percentages of what percentage is inherited versus sporadic, but it's also dominant. So the same thing, whereas
Uh-huh.
you're not a carrier, you either have it or you don't.
Interesting. Whoa, all the things you don't know to be afraid of. Okay.
Yeah.
Um, all right. So
That's one way of
when you
putting it.
have, right? So, okay. So you have a child with one of these genetically inherited predispositions to cancer. Talk to me a
Mhm.
little bit about how you talk about this to small children.
Right. So, and here the developmental stage is really important. So, for example, let's say someone's 3 months old when they get diagnosed with NF. I'm not talking to the child about this, I'm talking to the parents. But we do encourage that the diagnosis is part of their language, that they use the terms. as soon as the child is sort of old enough to say, oh, where am I going? Who am I going to? Oh, this is your Lynch syndrome doctor or your NF1 doctor. And it just becomes part of their identity. That's like I said before, I have dark brown hair, I have Lynch syndrome, or I have NF1. And it's not something big and scary. But as they get older, so usually I have a big conversation with the parents at the time of diagnosis, all the terrible things that can happen, all of the terrible things that usually don't happen, but we need to look out for, all the ways that I and my team are here to support them and to be there for them, what kind of surveillance they need, what kind of surveillance they don't need. So also
Hmm.
explaining what they don't need to worry about or what we don't need to do. And then as children get older, that becomes an opportunity at every visit. And I have to admit, I don't always do this well, but I have to remind myself when I'm seeing, let's say, a 6-year-old, I've been seeing since they were 3 months, but now they're 6. Now I have to give them the opportunity to ask their own questions again.
Hmm.
Or now they're 14, or now they're almost 18. So
Now they're
trying to
Googling and AI chat GPTing. Right.
Right, right.
Hmm.
So both making the visit with me an opportunity for the child to ask questions so I know where they're at and what they're ready to hear, what conversations we need to repeat, because the last time we had that conversation, they weren't old enough to be part of it. And for the parents to say, okay, well, I know what we needed to worry about when they were 5, but what about now? What
Hmm.
are we looking
Hmm.
out for now? And that can
Hmm.
change as the child gets older. But we do, unless the parent strongly objects, the kids are in the room the whole time. They're part of the conversation the whole time. When they're little, sometimes they're running around and not paying attention at all, but at least they know this is something we can talk about, and
Hmm.
that my team and I are the people they can go to for answers if their parents don't have the answers for them.
Yeah. Okay, I want to finish up with a question about mothering. When you are a mother um, of children who have a significant medical diagnosis and a complex medical diagnosis, either that we're watching and waiting or we're actively engaged in treatment. Talk to me a little bit about what you see in those moms and what you want mothers to know, or what you want us to understand for those who help mothers. Like, what are we thinking about from the mothering perspective? And I know fathers can be just as involved, but let's
Yeah.
just focus on moms. Let's give us a space this week. Go ahead.
So I think that for mothers, one really big challenge that I see, and this is a whole podcast in and of itself, is knowing when to give kids agency to make decisions for themselves.
Mhm.
Because mothers of sick kids are so used to being everything for that child. They read up on everything on the internet. They make notebooks full of their questions and records of doctor's appointments. They arrange their kids' lives so they can have as normal a life as possible while also making space for whatever treatments and appointments they need. They take so much on themselves that it can be hard knowing when you can step back and assuming the child is, cognitively and developmentally ready for that, start letting them make their own pill boxes, set their own reminders on their phone, maybe call and make their own dentist appointment,
Yeah.
So I think what I often try to encourage moms is when they can start to step back a little bit and to
Yeah.
know that you've done your part, you've raised this amazing kid despite all their challenges, and now how do we help them get ready to manage this on their own?
Yeah. Yeah.
You know,
Yeah. Yeah. And it's hard. And also recognizing their, like, the release of that responsibility can also leave them feeling incredibly unmoored.
yeah,
Like their whole focus was keeping this child safe, happy, alive, whatever, safe and alive, and hopefully happy. But I think that sometimes parents who are so intensively parenting responsibility wise, releasing some of that can feel very frightening. Like they may not realize how frightening it is, but also feels like, well, what if they make a bad decision? What if they forget their medication? What if they do something crazy and risk taking? I think there's
yeah.
threat in that.
And I think also along with that is really, I think every mother needs a reminder that you're a person first and a mother second, and
Yeah.
make space for yourself and time for yourself. You have needs as well, and those aren't secondary to your
Yeah.
child's needs. I'm talking to myself too. Again, I'm not
Yes.
always good at this, but for a parent or a mother of a very sick child, that's even more important. And I think for everyone around that mother, whether it's family members, a spouse, a therapist, everyone around that mother needs to remind them of that because we sometimes we
Absolutely.
need a lot of reminding, and sometimes
Absolutely.
even stepping in. Like I will go to that doctor's appointment, or if that's a lot to ask a mother not to go to a doctor's appointment, but I will stay over this weekend so you can do something. You need to take a break. And it's
Mm-hmm.
when a child is extremely sick, that might not be the best time for a mother to be able to take a step back. But hey, things are really calm right now. She's recovered from the surgery, your child. Why don't you go out with your husband, go out for dinner? I'll babysit. So I think
Yeah.
volunteering to step in when you can and giving mothers permission to
Mm-hmm.
take time for themselves and understanding that that doesn't mean they're taking time away from their
And the
child.
child. Yeah. Wow.
They're allowing themselves to come back stronger.
Any one or two misconceptions about parenting a child who has significant medical challenges that you might want to just make sure we highlight?
Um, Misconceptions. I mean, I really, for many things, I really drill down on that this is not your fault.
Mm,
And you can't always control the outcome.
yeah.
You might do
Yeah.
everything right and it still has a bad outcome.
Hmm.
And that doesn't mean you did anything wrong. I think,
Yeah.
again, mothers take a lot of blame on themselves. We try to control everything and trying to remember that there's a lot in medicine that we can't control.
Yeah. I think we'll leave it at that. I thank you so much, Dr. Siegel. This has been a special conversation. Unique, a little bit like one step to the side on mothering and reproductive mental health, but I think I don't really care. I thought it was phenomenal.
Thank you. This is really great. I appreciate the opportunity.
Thank you so much.
Have a good one.